Irfan, third year microbiology at Shaukat Khanum Hospital, Lahore. So the title of my presentation today is Tiny Clues, Big Diagnosis, a Microbiological Puzzle. So the history is a 25-year-old female who is a known case of osteosarcoma female. She's status post third cycle of chemotherapy on 13th of November 2025. She presented in emergency on 26th November 2025 with fever for 3 days and mouth ulcers for 3 days, generalized weakness, and inability to eat and drink. Her vitals on presentation, pulse was 138 per minute, blood pressure was 125 by 90, temperature was 38.9, and oxygen saturation was 98%. On review of systems, there was fever, malaise, fatigue, and odynophagia and oral pain slash mucositis on head, eyes, ear, nose, and throat examination. Rest of the examination of the systems was normal. So on head, ear, nose examination, there was all of it was intact except limited mouth opening and grade 4 mucositis. So we will see the WHO classification of these grading. In grade 1, there is soreness and plus minus erythema. In grade 2, there is erythema, ulcers, and patient can swallow solid food. Grade 3 and 4 are classified as severe mucositis. In grade 3, there are ulcers with extensive erythema and patient cannot swallow food. And in grade 4, mucositis is so much to the extent that alimentation is not possible. So based on this history, what are your impressions?
Does anybody want to share the differentials or put them in the chat box? क्लिक करना चैट बॉक्स पे देखने के लिए कैसे
वो आ जाता है ना पॉपअप 1-2 gram negative bacteremia. Okay.
Anything else?
Due to mucositis. Okay.
So Dr. Samreen is saying that this could be gram-negative septicemia or bacteremia due to mucositis or fungemia. That's why I think we can proceed with that then.
Okay. Dr. Naseem is saying mucositis and bacteremia. Okay. So impressions were post-chemotherapy mucositis and febrile neutropenia. So the investigations based on these impressions were ordered. So CBC, LFTs, RFTs, and electrolytes, CRP, serum lactate, and 2 sets of blood cultures, and culture specimen from other sites of suspected infection, and a chest radiograph were ordered. So what would be the next step further? So people are saying can be GPC or anaerobes as well. HSV, CMV, candidiasis, HSV. So next step would be empirical antibiotic therapy within 1 hour after triage from the initial presentation. And the choice of antibiotic would be okay. So basically anti-pseudomonal coverage, piptaz or cefepime or any carbapenem. And what do we need to start vancomycin here? So vancomycin is not really needed because there are no impressions of any catheter-related infection or skin and soft tissue infection. So or not even pneumonia. So vancomycin was not started. Um, we will also enter IV fluids, oral care agents, and paracetamol. A GCSF platelet transfusion. On investigation results, CBC, HB was critically low, 7.5. WBCs were also low, and platelets were also low. CRP was really high, 123. Lactate, LFTs, urea, and electrolytes were normal. So the treatment was started peptaz, paracetamol, sodium chloride, filgrastim injection, nystatin, chlorhexidine, and mouthwash for oral care. So blood culture results came after 48 hours. I'm going to show you a picture of a gram stain of the blood, and if you can see anything, you have to tell me and what it is. Sorry, I'm sorry. Do you guys see anything here or here? Here.
डॉक्टर सुमैया आप फेलो से पूछ लें, ऐसे नहीं बोलते।
अच्छा जी, जो अभी हम आपको जो ग्राम स्टेन दिखाई जा रही है, would anybody like to comment? And I would like to know the color of the bug and the structure and possibly the arrangement. If anybody can put that in the chat box or say it out on the mic. The chat box.
Wait. Residents from AKU, please.
Can you magnify your Zoom? Can you? हो सकता है क्या? Stop share करके.
इसी को प्लस कर
इसी को करें।
Microbiology residents from AKU. I'm going to start naming you people.
हाँ, इंडस वाले तो डॉक्टर जाहिद ने लिखा है ग्राम नेगेटिव रॉड्स।
और किस तरह के ग्राम नेगेटिव रॉड्स लग रहे हैं? अगर आप लोग रेगुलरली ग्राम नेगेटिव रॉड्स देखते आए हैं तो क्या ये आपके रेगुलर ग्राम नेगेटिव रॉड्स जैसे लग रहे हैं?
जाहिद प्लीज मजीद कमेंट करेंगे सवाल पे।
जो रेगुलरली हम ग्राम नेगेटिव रॉड्स देखते हैं यूजुअली थोड़े से प्लम्प होते हैं।
GNR.
Do these look plump to you?
GNR branching, GNR tapered and.
शाबाज़ कह रहा है कि these are they show mild bipolar staining and very thin. They are definitely thin. They're definitely thin compared to your regular gram negative rods. थोड़ी सी tapering नजर आ रही है. Some Sehba Seher mentioned that. अच्छा, इसकी arrangement कुछ इस तरह की is giving an impression of branching. क्योंकि because ये आपकी पहली gram stain है तो थोड़ा सा इस तरह का नजर आ रहा है. There were no spirals, ठीक है, but they were definitely thin and shortish and tapered. Okay, आगे चलिए.
मज़ीद explain करना चाहता हूँ. So based on this gram stain, what would be your differentials?
तो ऐसे कौन से ग्राम नेगेटिव रॉड्स होते हैं जो थिन टेपर्ड appearance देते हैं? Apparently we have a lack of micro residents in the meeting today because AKU has their morning meeting. अगर बाकी सेंटर से माइक्रो वाले मौजूद हैं तो प्लीज वो कमेंट कर दें. Someone saying nocardia. So we all know that nocardia is gram positive होता है. मजीद ये कि क्योंकि अभी हमारे पास आपको शुरू में ब्रांचिंग दिख रही थी तो चलो as a rule, thumb rule of thumb आपको एक partial acid fast definitely भी बना के देखनी चाहिए कि rule out करने के लिए कि nucardia है कि नहीं. But if we had to limit ourselves to gram negatives, उसमें
तो
फिर
भैया एक रेजिडेंट ने टेपरिंग एंड्स कहा है, तो उसी पर अगर एक्सपैंड करें अगर, तो प्रॉब्ली दे विल बी एबल टू टेल.
Okay, so I'm getting options here: Pseudomonas, Acinetobacter, Burkholderia, Fusobacterium, non-enterobacterial CGNR. Acineto क्यों नहीं हो सकता? कौन मुझे बताएगा? Acineto क्यों नहीं हो सकता?
हाँ, क्योंकि वो कॉक्सो पे सलाए होते हैं, ग्राम नेगेटिव.
सही सही. So क्योंकि Acinetobacter ग्राम नेगेटिव कोकोबैसिलाई होते हैं, तो ये वो तो नहीं है. ओके. Pseudomonas कभी कभी वो उटपटांग शक्लें बना सकता है, तो दैट इज अ पॉसिबिलिटी. फ्यूजोबैक्टीरियम एक हमारी डेफिनेटली पॉसिबिलिटी हो सकती है. हम आपने ये बताया था बॉटल कौन सी है? आपने नहीं बताया ना.
anaerobic bottle was positive.
somebody should have asked कि हमारी बॉटल कौन सी पॉजिटिव आई थी, तो ये हमारी anaerobic बॉटल थी. so someone's mentioned anaerobes as well, bacteroides. ठीक है, चलिए. I think we have enough differentials. Okay, आगे चले.
So we will get back to differentials, and culture inoculation, blood agar, chocolate agar, and McConkey agar were inoculated. This is the growth after 24 hours. This is a very fine growth, and on this growth, some biochemical tests were done, and catalase was negative, oxidase was negative, and gram stain from the colony was done from the plate.
एक मिनट, कौन सी
इज दिस एरोबिक और एनारोबिक?
इंक्यूबेशन कौन सी पॉजिटिव है?
हमारी एरोबिक पॉजिटिव.
ये एरोबिक इंक्यूबेशन की ग्रोथ है आफ्टर 24 आवर्स. और प्लेटिंग है और दिखा.
So 24 hours की यही है, आगे 48 hours.
I'm assuming 5% CO2 or more.
Yes, yes.
Yes, Dr. Javira, this is in CO2.
How much? 5%? 10%?
5 to 10%.
Okay.
आगे चलो.
This is the picture from the colony itself, the gram stain from the colony itself, from the plate.
तो was the colony pink colored? इसमें मुझे लग रहा है, तस्वीर में लग रहा है हल्का सा पिंक टिंज आ रहा है क्या?
Orangish tinge, a light of orange.
ठीक है, थैंक यू.
So this is the growth after 48 hours. Again, from the CO2 incubator, 5 to 10% CO2 incubator. Okay, so the colony morphology is basically, these are tiny colonies, 1 to 3 millimeter, and yellow to orangish in color. Okay, so for biochemical testing, API was inoculated, and should I tell?
Sorry, before we do biochemical testing, can you also tell us whether it was growing on nutrient agar,
on
McConkey?
No, Dr. Javira, did not grow on McConkey.
And did you try nutrient agar or tryptase soy?
No, it did not grow on it also.
Or MHA?
Only on
No?
blood and chocolate.
Okay.
Only on blood and chocolate. Yes.
All right.
And catalase was negative.
Yes. Catalase and oxidase were negative.
Okay.
Okay, so API NE was inoculated for non-enterobic reishi, and the positive reactions were nitrite, esquilin, and PNPG.
So why did you set API NE and for an organism which was not growing, not growing on nutrient agar? Why did you not set NH?
Because Dr. Javeria, for NH we set up only for Neisseria and Haemophilus. They won't grow on blood agar.
That is not so, but okay. That's your okay. Johnny.
Okay. So based on
Because what were what were the other biochemical? Did you inoculate it on TSI, or what was the reaction on TSI?
And motility?
it was not an enterobacter issue, so we did not.
We don't have biochemicals.
And also we don't have those biochemicals also.
Okay,
Yes.
okay, thank you.
Motility hanging drops से भी नहीं किया आपने?
No, Dr. Zaveria, we did not do the motility.
Okay.
Okay, so the identification, we are having discussing the differentials. Fusobacterium, this is the gram of the Fusobacterium, Capnocytophaga, and Leptotrichia. So identification was also done on moldit of MS, and it recognized it as Capnocytophaga sputigena. So the Capnocytophaga is gram-negative, long, thin rods which exhibit gliding motility, which we will show later. Capnophilic requires carbon dioxide for growth. It has spreading smooth or slightly granular colony, which is swarming due to gliding motility and yellow to orange in color. It is a facultative anaerobe and capnophilic. Catalase, oxidase, and indole production are negative. Escalin hydrolysis is positive, and motility is gliding motility. And its habitat is human oral cavity, which is a part of normal flora. And some species are also found in animal oral cavities. So for AST, there are no standardized guidelines in CLSI and UCAST. According to literature search, broth microdilutions, agar dilutions, e-tests using the breakpoints established for Hesse group or anaerobes can be used and were used. And our organism was susceptible to penicillin, ceftriaxone, and meropenem. So what would be the source of this organism in like septicemia in our case? Oral cavity.
So it is the normal human oral microbiota. So it could be the possible source.
Yes. The oral cavity
Sorry,
flora
it can be because the patient might be immunocompromised as well. Sorry, I missed the beginning of the session. So, like ma'am said, oral flora, immunocompromised. It can also be if the patient has does any alcohol use or asthenia. Sorry, I can't comment on the chat box.
Okay. Okay. So the oral cavity flora was more likely source of infection as the patient had the symptoms of oral mucositis. So this is basically a discussion of the Capnocytophaga species. So I'll be asking some questions and we'll discuss the answers in the end. Which body site is the habitat of Capnocytophaga sputigena in the mammals? Your options are listed: oral cavity of dogs, humans, or maybe female genital tract of dogs or humans. Answer अभी chat box में I guess लिखते जाए.
If you have a minute to put your answers in the chat box, and we'll follow the answers at the end.
Oh, okay. And Dr. Javeria. Because of the call,
so
Gramstein morphology.
If someone has put A as the answer, if someone would like to comment के dogs में कौन सा वाला कैप्नोसाइटोफेगा होता है?
discussion and paper and
Sure.
answers them.
So it's Khanum Morris. Okay. Thank you, Dr. Faisal.
Dr.
Okay.
Which of the following biochemical testing results can differentiate Capnocytophagus putigena from Canimorsis? So these are your options: catalase and oxidase with positive or negative. And we will discuss answers in the end. Which of the following resistance mechanisms may be found in multi-drug resistant Capnocytophagus putigena? Your options are CSP1, VAM-C, KPC, or NDM. Okay, so this is a facultative anaerobic capnophilic slow-growing fusiform gram-negative bacilli, which are normal inhabitants of the oropharyngeal flora. To date, 9 species have been described in the genus Capnocytophaga. It is an opportunistic pathogen associated with periodontal diseases and animal bites, causing systemic infection in both immunocompetent and immunocompromised hosts. It is isolated from oral cavity, including dental pockets, subgingival plaque, respiratory secretions, wounds, and blood. So these are basically divided into human oral associated and zoonosis associated. Human oral associated is Capnocytophagus putigena, granulosa, hemolytica, and others. And zoonosis associated are Canimorsis, Canis, Chynodegmi. So growth characteristics on blood and chocolate agar, the organism produces tiny pinpoint yellow-orange colonies when grown at 35 to 37 under 5 to 10% carbon dioxide or anaerobically, and would need an additional 1 to 3 days to grow to a larger diameter for recognition. It shows characteristic gliding motility, if you can appreciate. Here, if you can see the colonies spreading on the agar. So biochemical identification is catalase and oxidase tests can be done, and it is difficult to identify by phenotypic methods. Morditov MS can be used, as well as 16S ribosomal RNA gene analysis. This is again the gram stain of the Capnocytophaga species, and these are basically the biochemicals of all the species listed. So if we can see Capnocytophagus putigena has only esquilin hydrolysis positive and sucrose positive. And for Canimorsis and Chynodegmi, oxidase and catalase are only positive for these two species. Okay, so for AST testing, no CLSI or UCAST recommendations for susceptibility breakpoints for this genus. And it is challenging to perform or interpret AST results. Spectrum of antibiotics and duration of treatment is based on clinical reports, and in vitro susceptibility is based on the breakpoints for anaerobes or Hesse group, as were used in our case. So antimicrobial susceptibility of Capnocytophaga species using different methods, agar dilution, E-test, broth microdilutions, have shown that tetracyclines, chloramphenicol, meropenem displayed in vitro activities against this bacterium. In contrast, most strains are reported resistant to polymyxins, fusidic, fosfomycin, and trimethoprim. So beta-lactamase production, a high proportion of Capnocytophagus putigena isolates were beta-lactamase positive, and that beta-lactam resistant isolates, which are resistant to amoxicillin, amoxicillin plus clavulanic acid, and third generation cephalosporins, they harbor the beta-lactamase genes, beta-lactamase CFXA or beta-lactamase CSP1. So A2 and A3 were responsible for extended spectrum resistance to beta-lactam antibiotics in Capnocytophaga. So CSP1 is a novel extended spectrum beta-lactamase produced by clinical isolates of Sputigena. Thus, it is important to highlight that Sputigena carrying beta-lactamase genes can be resistant to amoxicillin, amoxicillin plus clavulanic acid, and third generation cephalosporin. This is an article showing the high prevalence of beta-lactam and microlide resistance genes in human oral Capnocytophaga species. So for detecting the beta-lactamase testing, nitrocephin test can be done. Cephinase discs are used, which are impregnated with a cephalosporin nitrocephin solution, which is normally yellow or negative when yellow, but changes color to red or a bit purplish when a beta-lactamase hydrolyzes the beta-lactam ring, and we say the test is positive. Means beta-lactamase is present there. So clinical implications would be bacteremia, sepsis common in immunocompromised populations, pleural empyema, chorioamnionitis, neonatal sepsis, septic abortion, endocarditis, endometritis, ophthalmic lesions, osteomyelitis, soft tissue infections, sinusitis. So canimorsis and chynodegmy cause infection following dog or cat bites, septicemia with serious sequelae in alcoholics, and patients who have had splenectomies can result. And these two can cause endocarditis, keratitis, meningitis, brain abscess, respiratory tract infections, septic arthritis, soft tissue infections, and infections with chynodegmy are rare but may be localized or systemic. So we will discuss the answers to those questions. So first question was, which body site is the habitat of Capnocytophaga sputigena in mammals? And the answer is B. Most bacteria in the genus Capnocytophaga are normal but not prominent members of oral or nasopharyngeal microbiota of animals or humans. Sputigena is a part of normal oral flora of humans. Though not present in the female genital tract, sputigena introduced into the vaginal tract during pregnancy may result in preterm labor as well as septicemia and respiratory failure in newborn children. So the next question was regarding biochemical testing, and the answer is again B. Catalase and oxidase negative are for sputigena, and we discussed earlier that canimorsis and chynodegmy are the only oxidase and catalase positive species in this genus. So the resistance mechanism, as we have discussed, the resistance mechanism in sputigena is CSP1, which is a beta-lactamase, and we have already discussed this. So take-home points would be Capnocytophaga sputigena is a fastidious, facultatively anaerobic, indole negative fusiform gram-negative bacilli. It inhabits the oral cavities of humans and may cause severe periodontitis. It is an opportunistic pathogen that may cause extraoral infections in immunocompetent and compromised patients, including bacteremia, community-acquired pneumonia, and empyema. It is considered a potential risk for second trimester abortion, chorioamnionitis, and neonatal infections. Multi-drug resistant Capnocytophaga sputigena strains carrying beta-lactamase genes, CFXA or CSP1, have been isolated and are considered resistant to amoxicillin and most cephalosporins. These are my references. Thank
you. So if there are any further questions, you can ask them now or put them in the chat box, please.
Ma'am, if we were to differentiate Capnocytophaga with Pasteurella, would it just be because Pasteurella is non-motile and it has a cocobacilli appearance? Rather, this is also an animal bite and the other one is also. So do we just differentiate it on the basis of gram stain and its motility? Thank you. Sorry, I can't put my comments on the chat box. It's not working.
तो एक तो yes, क्या कहते हैं, based on the motility that could be one. दूसरा ये कि usually both of them, जैसे both of them are fastidious, both of them wouldn't grow on your McConkey. कुछ biochemicals तो basically आपको setup करने ही पड़ेंगे. Unfortunately, जैसे हमारे case में था कि we don't have basic biochemicals available with us. But उसमें इंडोल पॉजिटिव बताया कि हमारा वाला भी इंडोल हमारा इंडोल पॉजिटिव पास्टेरेला जो है यूजुअली आपको इंडोल पॉजिटिव होता है. एंड ऑफ कोर्स अगर आपके पास फर्दर एनहांस टेक्निक्स हैं मौजूद आपकी लैब में तो इट विल हेल्प यू आइडेंटिफाई योर बग.
Is it possible to identify without moldy? Any ने एक हमारा like वो कर दिया था, जोन नैरो कर दिया था कि it might be that.
So आपके पास अगर NH होती तो NH थोड़ा सा आपको डिफरेंशियल्स में हेल्प कर देता है. yes. But obviously, it'll perhaps help you get to the genus rather than the actual species. What did we give to the patient? Does anybody remember what we gave? Initially, this was Piptas, but I think based on
Piptas empirically start.
I think it was Miro पे शायद शुरू कर दिया था. क्योंकि अब केस थोड़ा पुराना हो गया, nobody remembers उसको क्या मिला था.
Miro would be quite broad अगर penicillin से भी sensitive था. So I was just, I mean, I don't know, you can't really say it's sensitive because you don't have the points, but
So that's, I think, that continues.
They wouldn't have opted off for narrow spectrum beta lactate because she was already neutropenic. So I think
oh
narrow
right,
beta
हाँ, वो भी तो था.
Agar ho gaya, then probably they must have yes. That's what our practice is.
Thank you. Right. So if there are no further questions, we will end the presentation over here. Thank you, everybody. Thank you.